Hello, everybody. Welcome to my channel, Island Daily. My name is Dr. Iman, and I'm an optometrist. And welcome to the part 2 of corneal topography. In this video, we are going to discuss different corneal maps and how to interpret those. So let's get started. Now, there are three kinds of maps. The first one is the pachymetry map. The second one is are the curvature maps, and the third one are the elevation maps. So first, we're going to talk about the pachymetry map, and the pachymetry map is going to tell us about the thickness. Now, if you look into this picture has been taken from a pentacam, and these readings are not related with this map. Now, first, we have to look the color coding of this map. So this right here tells the most thickest part, and this tells the most thinnest part on the cornea. Since you can see that we have, wait, a blue portion in the periphery and green portion in the center, what does it tell us? It actually tells us that the cornea has a thicker portion in the periphery and it is normal in the center. And this is a normal pachymetry map because the cornea is 700 or 600 microns in the periphery, and it is about 550 microns in the center. So it is a map of a healthy individual. Now, if there are some yellow or red portions, the yellow portion tells us that it is inclined towards thinness, and red tells us that it is actually, this portion is actually very thin. So, what does this tells us? We have this y-axis and x-axis, and we also have some meridians right over here. So, the first, this is a right eye map, and these axes are given for us to locate the location of the thinnest point. Now, first, look into these readings. This point right over here tells us the thinnest point. Now, do not ever confuse the thinnest point and the central point. Now, we actually know that the thinnest point lies in the center, but not in every case. If there is some kind of ectatic disorder like PMD, pellucid marginal degeneration, or keratoconus, the thinnest point is not going to lie in the center. In fact, it is going to slide inferiorly, right? So first thing, you have to check the thickness of the thinnest point and its location. Since this location is given in radians, you can also convert this in x and y axis, which is quite convenient. The formula for this is x is equals to r cos theta and y is equals to r sin theta. And with that help, you can locate the location of x and y axis. You can locate the location of the thinnest point. Now let's say if the x is 0.7 and the y is minus 0.7, what does it is going to tell us? It is actually going to tell us that the y-axis, it is in minus, which means that it is inferiorly. It is going to lie somewhere right here, right? And it is 0 + 0.7, which means that it is going to lie somewhere over here, right? So this tells that the cone is right here. So the y-axis should not be greater than 1 millimeter, right? It should not be greater than 1 millimeter. Otherwise, it it is a huge risk of developing keratoconus or any other ectatic disorder. Now, this point is telling us the thickness of the central point, and this is going to tell us the complete corneal thickness. This has the thickness of the midpoint, and this is going to tell us the thickness of the periphery, and this is going to tell us the total corneal volume. Now, you have to look into all those points. Why? Because there are some ectatic disorders where the periphery starts getting thinner. That is Tyrian marginal degeneration. In that kind of degeneration, the periphery starts getting thinner, and the center remains normal. So this was the whole point, and this is how you're going to read the corneal pachymetry map. You have to see first you have to see the color coding, then you have to see the thickness point, and then you have to locate where the thickness point is, and of course you also have to see look for other parameters. Now, coming back towards the curvature maps. So, how many curvature maps are over there? Now, the first one is the axial, also known as the sagittal curvature map, and the second one is the tangential or the local, also the instantaneous curvature map. Now, we know that the pachymetry map will give us reading in microns, and these curvature maps are going to measure the curvature of the cornea with respect to a reference line. Now, what is the difference between the axial and the tangential curvature map? There's a very slight difference. Now, this right here is the axial curvature map, and this right here is the tangential curvature map. What is what what's the difference? So in the axial curvature map, it assumes one point as the center of uh, one single optical center for all the points. So it is going to measure this according to this single central optical center. It is going to measure all the positions of the cornea. So with the help of this, it is going to make a reference image, reference line, and this is the patient's cornea, which is like this. Since the axial curvature map actually flattens towards the periphery because it is actually a very perfect sphere, and our cornea is not a perfect sphere. It actually flattens towards the periphery, and it is slightly steeper in the center. But since the axial curvature map actually ignores the periphery, and the periphery flattens, so it might actually might sometimes miss very early keratoconus, right? So to resolve this problem, a tangential map was introduced which will take tangent wait which will take tangent of each point, and with the help of this, it is going to build a reference line, and due to this, a very slight change in the steepness of the cornea will not be ignored. Now, the thing is that with you have to look these maps side by side, and you also have to look for the K readings. K1 and K2. You also have to look their reading. So the normal keratometric reading is between 43 and 44, all right? And minus 0.75 of diopter difference is quite normal because we all have physiological astigmatism, of minus 0.75. So you have to look if the readings are normal. If if the K2 reading is more than 47 diopters, it is not normal, right? So you have to look for keratometer readings as well, and you have to also have to look for excess, like if it lies in 90 and 180 degrees, which means that it is a regular astigmatism. But if even if the power of the astigmatism is not much, but if the axes are something between 145 and other than 90 or 180, this means that this isn't a regular astigmatism. This is something called a oblique astigmatism, right? So while viewing these maps, while assessing these maps, you also have to look for keratometric readings. Now, let us look for a real map, and then we'll assess what is in those maps. So this is a document that I've made for my university students. So as you can see that there is a common optical center in the axial sagittal map, and there are multiple tangents in the tangential map, due to which the periphery is not missed, and a slight change in the steepness of the cornea is assessed. Now, still you have to what do you have to look for in these maps? You have to look for patterns it is going to make. It is actually going to tell you about the curvature of the your cornea with reference to these reference lines. In these maps you have to look for different patterns, which is going to and these patterns will be in diopters, right? Now, since the tangential map is, even if the tangential map is more reliable, you have to look for the axial sagittal map. Why? Why? Because the axial sagittal map is going to give you a overview, and there are many artifacts in the tangential map. Even if your tear film is slightly irregular, it is going to give you a slight irregularity. So, the first thing is that you have to first look for the axial map, and then you can also go for a tangential map. And even if the tangential map gives you any red zones, you can make patient use any lubricant, and you can scan the patient. Now, the first pattern, it's a very normal pattern, is a round spherical pattern, a green pattern, and it can also be a pattern that you have seen in the pachymetry map. The periphery might be a little blue, and the center might be a little green. It can be round, and it can be a little oval. I couldn't find an oval map on the internet, or I didn't have, and none of my patients had an oval curvature map. So the most important are the bow patterns. So you have to see this right here is a with the rule astigmatism. This right here is an against the rule astigmatism, and this right here is an oblique astigmatism bow pattern. Now, what do you have to look for in these bow patterns? Now, we all know first thing is that you have to see the superior and inferior bows have a similar thickness. None of the bow should be more steeper, and especially the inferior one. Now, the inferior and superior bows should be of uniform thickness. A difference of a difference of 1.5 diopter is acceptable if the inferior is slightly thick, more steeper. But if the superior bow is slightly more steeper, a 2.5 diopter difference can be acceptable, since it is very, very, very rare for ectatic disorders to develop a steeper cone in the superior portion, right? So the inferior steepening is very, very much in the red zone, and it should not be, and there should not be a difference of 1.5 diopter when inferior is steepening. Now, the second thing is, so how will you document it? You will document it document these as symmetrical bows. This one right here is the with the rule astigmatism, because the vertical meridian is more steeper, and the this one right over here is the against the rule, because the horizontal portion is more steeper, and this right over here is an oblique portion, because it is not in the 90 and 180-degree meridian. Still, it is not that much steeper. It lies somewhere close to 90 degree. Now, what is right over here? This this is a bow pattern which is asymmetrical, which means that the inferior bow is quite a lot steeper than the superior one, right? So this is actually a red signal that there might be something right there going the cornea, and you have to look for other readings as well. Now, what is this? This right here is a skewed radial axis. What is a skewed radial axis? Where the bow is not actually in it's not straight. The superior bow right over here is actually, rotated more than 22 degrees. Now, there is a normal range. If the bow is less than 22 degrees skewed, it is acceptable, but it is skewed more than 22 degrees, like it's skewed more than 30 degrees, so it is not acceptable, and this is a sign that it might be some kind of ectatic disorder. And this right here is a very, very irregular pattern, and this kind of pattern develops in mostly advanced cases of keratoconus or uh, these kind of activity disorders. This right here is a crab claw pattern that is a very typical picture of PMD and keratoconus. So these were some patterns that you have to look for in the axial curvature in the curvatural maps. And if I zoom it a little, you have to look for these readings. These readings are going to tell you how much flatter, how much steeper the cornea is. So you have to remember one thing, that if even if there is nothing written or right here, you have to you can tell by looking at the map that if the readings are in diopters, it is a curvatural map, right? Now, the third map was the elevation map. Now we have two different types of maps. The one is BFS and the other one is BFTE. Now, the BFS means best fit sphericity, and the BFTE means best fit toric eccentricity. And both of these maps have an anterior plus posterior division. Now, what are these maps telling us? There is a reference, same like in the tangential and axial one, we have a reference surface. In BFS, it is actually a total sphere, and in BFTE, as I've told you before, the surface is going to be a little oval, which means that it is going to be less flat in the periphery. So this is the reference line, and this is the cornea of the patient. So it is actually going to tell how much the cornea is higher from the reference line, and how much is it below from the reference line. So the values in both of these maps are going to be given in microns and the steeper regions are going to have a plus value, and the flatter regions are going to have a minus value. Now, let's look for these maps in the document. Now, these maps are taken from a pentachem, and this right here is a best fit sphericity anterior elevation, and this right here is a best fit sphericity posterior elevation. Now, as you can see that there are some signs +9. This is +9 microns higher than the reference line. This right here is +2, +6, +10, right? And look for this in the BFTE map. These right over here tells that this is a map of a keratoconus patient. So this tells that this is -20 flat right over here, but you can see that the cone lies over here, the thin spot is over here, and this is +22 to +20 microns higher from the reference line, right? And this right over here is 30 plus 47 microns higher than the reference line. This picture is also of a keratoconic patient. Now, the key point is that the posterior maps are slightly more prone to, if the corneal curvature is actually going to increase, the posterior surface is actually going to increase before the anterior side. So if there is any red zone in the posterior map, this means that the cornea might develop keratoconus in the future, or they might, the cornea is not quite healthy, and it can develop an ectatic disorder. So you have to look for these points while referring that patient into refractive surgery. So these were the maps, and you have to look for normal values. So I have made this chart. So the normal values in the interior elevation is +12, and in posterior it's +17, and it is suspicious if it is between +13 and +15 in interior and +18 to +20 in posterior elevation. And it's very risky if it is more than 15 in the interior and more than 20 in the posterior elevation. So if your patient is a myope or hyperope, the value should be less than 8 microns in the interior elevation and less than 18 microns in the posterior elevation. And if it is hyperope, it should be less than 7 microns in the interior elevation and less than 28 microns in the posterior elevation. So if so this is the maximum which I could cover in a YouTube video. So there are many more videos to come regarding corneal topography. Stay tuned for that. If you like my videos, give it a like and do subscribe and do share it with your fellows. Thank you for watching and take care.